All right. Thank you guys so much for joining the session today. I hear there's a little bit of echo, but hopefully that goes away. My name is Hiba. I am an intern with the Illinois Department of Public Health. I'm just giving a brief introduction for our speaker today. So today we have Dr. Scardina speaking. Dr. Scardina is an Antimicrobial Stewardship Coordinator and Infectious Diseases Clinical Pharmacist at Ann and Robert Lurie Children's Hospital of Chicago. Dr. Scardina has presented at international infectious diseases conferences and has published manuscripts on topics related to antimicrobial stewardship. So we are so excited to have Dr. Scardina, and I will hand over the mic to her so we can get started. Thank you so much.
Thank you for the introduction, Hiba. So today, our objectives are to describe principles and strategies of pediatric antimicrobial stewardship to identify some potential challenges of these particular efforts specific to the pediatric population, as well as to outline some potential stewardship initiatives and interventions that we can implement at our individual institution. And by doing this, I'll review some literature in regards to what other institutions have done and follow up and the conclusion in regards to some of our interventions here at Lurie Children's. And these are abbreviations that are commonly utilized and you'll see throughout the presentation. So some background information. Antibiotics are the most common class of medications that are prescribed among children. And a significant portion, which is probably not a surprise, of these antibiotics are unnecessary. And literature has shown that when patients in an outpatient setting have ER visits, 50% of these adverse drug effects are attributed to antibiotics, with a higher incidence in children with less than 2 years and then decreasing as they get a little bit older. So we can see the significant impact in regards to inappropriate antibiotic use within the pediatric population. Listed here are common oral antimicrobials that are prescribed within the pediatric population, and it lists in a bar graph the rates of ED visits for patients between and during the years of 2011 and 2015. So listed at the bottom are the specific antibiotics, and then on the y-axis we have the rate per 10,000 dispensed retail prescriptions. And we see a trend that as patients in that younger age bracket of less than 1 to 2 years of age have a higher rate of them actually being having these ED visits secondary to adverse drug effects. And then this lessens as they get older. And that flips when we look specifically over to the right for our Bactrim, and that may be due to multiple factors, but one in regards to decreased use in our younger population. So we do see the impact in regards to the management and care of our patients and the incidence of ED visits secondary to antibiotic use. So this is some background information that I'm sure we're familiar with in regards to the core elements. So this is something that we can do as stewards in regards to trying to minimize some of those adverse effects and the utilization or unnecessary utilization of antibiotics within the pediatric population. And this was endorsed and created by the CDC back in 2014, and thus has been endorsed by the Joint Commission in regards to stewardship efforts from a hospital standpoint or setting. This has been modified for various other clinical situations, such as outpatient or for acute care, but some of their core elements are based off of what we see for the hospital setting. So one of the important things is to have leadership commitment, to have someone that is accountable, such as a physician or a pharmacist, having expertise in this particular area, and then action. So this is what we'll talk about for the majority of this presentation is in regards to the interventions and some of the things that we can do, as well as tracking of our efforts. We want to be able to speak to some of the things that we've done and report that to leadership. And then as we all are aware of, is in regards to education, that's important, not something that has been shown to really drive a stewardship program, but it is a consistent undercurrent of a successful program. Key members and departments of the stewardship program include your physician and pharmacist leaders, and then for the pediatric setting to have individuals with stewardship experience as well as either pediatric experience or a willingness to be able to implement some of their stewardship training for the pediatric population. Hospitalists are important because then you'll have someone, frontline providers, that can actually help to speak to the stewardship initiatives and being able to be on that front line to drive those. Data analyst is very helpful in regards to generating reports, being able to have concrete data for your utilization of antibiotics as well as for micro reporting. And then also if you want to report to NHSN, they can assist with that. In regards to nursing, it's very helpful to have a nurse on your stewardship program or in your within your stewardship committee, is because they, at the front line as well, may be able to alleviate some of the parents' concerns regarding the use of antibiotics, or to even explain maybe why they may not necessarily need to. That could just be a secondary clinical individual that could assist in helping the family understand why those need to be avoided if necessary. It's good to have a good relationship with your clinical microbiology and laboratory department in regards to generating your antibiogram, as well as if you want to implement a rapid diagnostic test, that you would be able to collaborate with them, or if you want to modify the way that susceptibilities are reported, that either some that are suppressed, then that's a way that you'll be able to have those conversations as if they're included into your stewardship committee. Infection prevention would be helpful to have their input, especially if there is an increase in regards to a resistance pattern or an outbreak, that you'll be able to perhaps target or provide your stewardship expertise to help to alleviate that. And then another department that we're seeing more and more incorporated into stewardship is the Center for Quality and Safety. So with my own experience, that they have been very essential in regards to being able to identify the appropriate resources and being able to provide their input to make sure that everyone that's involved in the care of the patient, if you're starting a new initiative, that you have the correct people at the table to be able to help make sure that you're that they're able to highlight potential barriers to trying to implement that initiative, and even can help in regards to disseminating education throughout the entire hospital. So some of the challenges of pediatric stewardship specifically can include the following. Generating support for leadership and clinicians. And this is mainly in regards to trying to identify someone, if you are in a hospital that has adults as well as pediatrics, trying to have an individual on the committee that can speak to the pediatric population and has expertise in that area. Also, our clinical studies and guidelines primarily focus on the adults. And so therefore, the recommendations may be stated for the adult population, and you may have some hesitancy from clinicians in the pediatric population in regards to the applicability of that information for their special population. We also have a lack of pediatric specific dosing information, which means that sometimes we have to look into clinicaltrials.gov or alternative sources than what you may typically see in the adult population to be able to determine the appropriate dose, which that can impact in regards to some of your stewardship efforts. Also, there may be a difference in your antimicrobial susceptibility pattern or profile for patients, for pediatric patients. And this may be due to, if you do have a adult and pediatric hospital, that some of that resistant pattern may be driven more from your adults. And so therefore that may lead towards more broad spectrum empiric therapy that may not be necessary for your pediatric patients. And then also in regards to resources, and I think that that kind of covers in regards to adult stewardship as well, but we highlighted some of the additional resourcing issues that may come about. The IDSA guidelines provides us with great strategies in regards to ways to overcome some of these challenges that we highlighted. So we have education in regards to augmenting our stewardship initiatives, as well as computerized clinical decision support systems. However, there may be some limitations with that because it's resources may limit the utilization of that or implementation as well. We can also utilize prescriber-led antibiotic review. So that's at the 48-hour timeout, and we'll talk about a study later on in the presentation regarding that. And then also having physicians lead the review at that stop orders as well. Guidelines are important. They can be specific for indication, for empiric or definitive therapy, and want to provide as much details in those guidelines if possible in regards to the dosing frequency and how long, and then also for patients that may have a beta-lactam allergy, how to manage those particular cases. And it's always great to be able to have these guidelines at the point of care. So if the clinicians are able to have accessibility to this so that they can implement it. And some of our other interventions that we're aware of in the hospital setting include prior authorization, prospective audit and feedback, as well as handshake stewardship. And we'll go through an example of that specifically in the PEDS population. So after coming up with all these various initiatives, then we want to be able to determine what outcomes we want to track. So specifically within the adults as well as PEDS, then we may look at clinical and process outcomes. And some of these particular outcomes may have some limitations within the pediatric population. For example, the incidence of C. diff is something that may be reported for a stewardship outcome. And hopefully we see a decrease within the adult population after, depending on the specific intervention. However, this is not readily observed within the pediatric populations. And this may be due to the fact that pediatric patients at a certain age are maybe colonized. And so therefore, if it is positive, doesn't necessarily mean that they have an active infection. So there's a limitation in regards to solely looking at an outcome for incidence of C. diff after implementing a stewardship intervention in your pediatric population. A second outcome is in regards to antibiotic resistance. So this is a dynamic process. It may take quite some time to actually see an impact on your resistance pattern after implementing a stewardship initiative. And then there's multifactorial in regards to the reasons for the development and transmission of resistance. There may have been a lapse in regards to infection control processes. And so that could be the reason in regards to why you see changes in your resistance pattern as opposed to stewardship efforts. Another outcome includes antibiotic-associated adverse events. So the limitation with this is in regards to reporting. So even though this may be noted, and as it regards to an adverse event, it may not always be documented and easily accessible for clinicians. The length of stay and readmission can also be multifactorial and may not be associated solely with stewardship. And mortality is something that is difficult to link back to our initiatives and is less common and rare within the pediatric population. So when we're looking at some of our pediatric stewardship outcomes, then we may actually consider evaluating the lack of worsening of these as opposed to having a significant impact on those. So our first stewardship initiative for the pediatric population that I wanted to highlight is a study that incorporated a lean readiness and metrics board. And this was done in an effort in order to improve the communication and efficiency of a stewardship program. And what they did is they went from having the monthly stewardship meetings, they decreased it down to a weekly 15-minute huddles, and they reported their results within that first year of implementing that. They developed 5 shared metrics that were based off of what the team had decided would be most beneficial for their stewardship program. And so this may seem like a lot to undertake when initially looking at it, but we'll take it step by step to kind of digest this information. So if we're looking at this upper part of the readiness board, then this is a visualization of what's going on with your ID department and your stewardship program in specifics. So over to the left, it provides the workload. So it tells us exactly how many patients are on service, if there are any pending questions, which clinicians are on service at that time, if there are particular learners or trainees that you have or shortages that you have within your hospital, if there are resistance patterns or outbreaks that the team needs to be made aware of, as well as the reports, the status of their reports that they have for their stewardship program. And the green means that there's no issues with it. The red means that there's something that is non-functional and needs to be addressed. The quick hits and the big issues are 2 ways that you can identify quickly what are things that are negatively going to impact your stewardship program. One within the next 3 days, and that's quick hits. And big issues are larger stewardship issues that need to allow further collaborations with other departments that may take additional meetings, but at least it's something that's at the forefront of everyone's site so that they're aware of this is something that we're going to be working on. Then you also have your announcements and your accomplishments. And listed at the bottom are these various metrics that the team has decided that they wanted to work on, and then their outcome and process and the current projects and their efforts to try to address those metrics. So it helps the entire team to be able to, in a visualization, identify what's going on with their stewardship program. Are there certain things, projects that need to be updated? And this was something that was discussed in that 15-minute huddle. The RMB was updated by the stewardship pharmacists or the data analysis at the beginning of this program once they implemented it. And then over time, they actually rotated that so that they could spread the workload amongst the rest of the committee. And one of the outcomes that they looked at after implementing the readiness board was their disagreement with some of their recommendations. So listed over to the far left, and as we pan over to the right, is the percentages of disagreements with their recommendations. And this is our linear slope of disagreement. So we see that it's fairly stable or slightly going up towards prior to their implementation. And then that slope started to decline after they implemented this readiness board. And so this was found to be statistically significant. This as well, I'll walk you through this. This is a heat map that their data analyst was able to complete a segmented regression model in order to determine if there are certain services which are listed over on that y-axis and the indications that they had the most disagreement with. And that darker shade identifies if there was a higher percentage of disagreement. So how would this be implemented and how would this actually be helpful for our individual stewardship programs? So if we notice that there's an area where we have a higher percentage of disagreement, then that may be our next stewardship effort. And so therefore that would go into our big issues of the readiness board of a potential project that we would be able to collaborate with that specific service and see if we can improve that disagreement percentage. And so hopefully over time that this goes from a dark shade to much lighter. Handshake stewardship. So we talked about this a little bit earlier in regards to our different initiatives that are highlighted from the guidelines from IDSA. So some of us, I'm sure, over the last year plus have not had a handshake, but handshake stewardship is nothing to be weary of. It's just noted as that because it's an in-person agreement between two different people. So with handshake stewardship, it was a lack of restriction and prior authorization. So none of the antimicrobials were restricted at this particular institution. And so the pharmacist and the physician reviewed active orders at that 24-hour mark and at that 72-hour mark for all of their antimicrobials towards the end of this rollout period. And what they did is they rounded with the teams and provided feedback in person. And listed at the bottom is a nice timeline in regards to their pre-planning and post-implementation. So we see pre-implementation, so this is even before they had a stewardship program, is that they did have activities of IV to PO policy, and then they had their yearly antibiogram. Once they started their planning period, this was actually a way that the physician, the stewardship physician, was able to start to build those bridges. So there was a provider survey that was sent out during this time period. They did additional QI training, and then they started to implement clinical care guidelines, and those are specifically listed there as to which guidelines they implemented during this planning process. And so once there was additional support with a data analyst and a pharmacist, they were able to have and implement the stewardship or handshake stewardship at their institution. So let's see what exactly happened after they implemented this. And these slopes are something that we saw earlier in the presentation. And so during this pre-implementation, we saw an increase in regards to our days of therapy for hospital-wide antimicrobials. It started to slightly go, well, I wouldn't say slightly, but it did go down during the planning period. And this may be due to mainly in regards to the clinical care guidelines. And then we see an even greater slope after they implemented handshake stewardship. And this is also mirrored when they look specifically at their vancomycin utilization. So we can see that having clinical care guidelines are helpful in regards to having a positive impact on your days of therapy, but we can see the significant impact that handshake stewardship would have. And their specific data is listed here. So they did have a decrease in their antibacterial use, and that was found to be statistically significant. At this institution, amongst all of their ICUs, the PICU had the highest amount of their antimicrobial use, or antibiotic use rather, at the initiation of the study and handshake stewardship, and that even was declined or decreased after they implemented this initiative. And then the HEMONC ward or floor was actually also had the highest amount of antibiotic use in the entire hospital. And so they also had a positive outcome when they implemented handshake stewardship. It can be difficult in regards to stewardship efforts and having a positive outcome when you're looking specifically at your antifungals and antivirals. Why is that? That may be due to some of the utilization is driven by protocols and policies, and so that may be harder to kind of have an impact on that. But we didn't necessarily in this study see a significant change except in that hematology oncology department. And so they did see a decrease in both their antifungal and antiviral. So from looking at this particular study, if we do have the resources, and mind you, that was having pharmacists, physician, data analysts, and then several hours, it took 3 to 4 hours out of their day to be able to do handshake stewardship. We do have those resources, then we can see the positive impact of utilizing handshake stewardship in regards to our days of therapy. The next part that I wanted to highlight is in regards to the specific changes that we saw. One was that change in that slope. They provide the specifics here. And so as we noted that all antibacterials, when they looked at the plan versus the post, we could see the impact of handshake stewardship. And then what we see here is for the specific antibiotics is when during that planning period, they had CCGs or clinical care guidelines that they implemented, one of which was appendicitis. And so the change in their slope when they went from plan to post, as well as pre to plan, it may be secondary due to the appendicitis clinical care guidelines. So we can see the impact that just by having that new implementation of guideline targeted towards decreasing your broad spectrum antibiotics can have on your days of therapy. And of course, as if squeezing a balloon, what we noticed too was that we saw an increase in regards to their utilization of ceftriaxone. But when we look at the broader term in regards to the impact and exposure to your carbapenems long term, then that may be something just to be mindful of, that when you do see an increase of or decrease in one antibiotic, you may see an increase in the other, and that can be justified based off of your initiatives. And this in particular was in regards to the initiation of appendicitis clinical care guidelines. Another outcome that we typically look at as well as leadership is in regards to the cost. So all of this time and effort and resources were utilized for handshake stewardship, and they did not see a change in regards to antibiotic loss or cost. The thing to consider is that we have to look at what are our high cost items. In this particular study, their high costs were topical. Actually, 30% of their antimicrobial budget was based off of topical antibiotics. And so they actually did not include that in their analysis. So if they targeted their initiatives towards those topical antibiotics, you may have seen a difference in regards to the cost. They did know, excuse me, during this study a decrease in their hospital onset CDI, and this may not necessarily be secondary to their stewardship efforts. They did have a change in regards to their infection control policies and their procedures specific to Clostridium difficile, and that may be why they notice a decrease in that particular rate. And some of our other outcomes that we look at for clinical outcomes those were also not negatively impacted after implementing their handshake stewardship. I thought this was a wonderful study because what they did is they wanted to make sure that this is sustainable. So many of us have stewardship efforts, and at the beginning we may have enough resources and bandwidth and support to be able to initiate an initiative, and over a period of time we may not be able to sustain that. But what they were able to note is that that decrease in their days of therapy for anti-infectives and antibacterials was sustained 5 years after they implemented this. As we noted before with the antifungals as well as the antivirals, it stayed pretty stable, but they did continue to have that positive impact in regards to their days of therapy. And also, at the beginning of our presentation, we talked about exposure to antibiotics and what that can lead to in regards to adverse drug effects. What they noticed is that during that 5-year period post-implementation, they had less patients that during their hospitalization were exposed to antibiotics, and so or anti-infectives rather. So we could see the multiple benefits of being able to, if we have the resources, implementing handshake stewardship. Next, I wanted to look and talk specifically about a prospective audit feedback study where they targeted their high-risk patients. And this is patients that were in the PICU and the neonatal intensive care, as well as the hematology oncology floors. And what they looked at is specifically patients that were on broad spectrum antibiotics for greater than 48 hours and provided recommendations. So listed here are those particular recommendations that they provided, either stopped, convert over to oral therapy, or or recommending to narrow therapy. And the percentage at the top, that number, is a percentage of times in which they actually had a stop order, or the number of times in which there was disagreement. And so what we notice is that the highest recommendation, or the most likely recommendation, is to actually stop therapy. We can see that kind of across the board. And 43% of all of the reviews that they did have were conducted amongst these high-risk patients, and listed there are the results from doing that prospective audit feedback. And as we mentioned before, we typically may want to look at some of the outcomes such as mortality, Clostridium difficile, and readmission. This particular study did look at that, and they noted that agreement with a stewardship recommendation did not negatively impact or increase the odds of acquiring hospital-acquired Clostridium difficile. They also noticed a decrease in the incidence of all-cause mortality during this time period of this initiative. And they also noted that a stop recommendation that they provided was not associated with an increased 30-day readmission. So that's encouraging to see that having that recommendation of stopping therapy did not negatively impact in regards to them requiring readmission. We also have the length of stay noted here, that there was actually a decrease in the length of stay amongst patients in which they agreed with the stewardship recommendation. So these are some of the outcomes that we may look at because they're traditionally analyzed for stewardship efforts. And so you may have some positive outcomes from doing that. But we also have to keep in mind that it may not be solely secondary to stewardship efforts. It may be multifactorial. But we definitely do not want to see a worsening of their length of stay or their Clostridium difficile rate or their mortalities during this time period of a stewardship intervention. And the third study that I wanted to look at is in regards to antibiotic timeouts. So this was implemented at 6 hospitals, and this included adult as well as pediatric ICUs and general floors. And they specifically looked at patients that were prescribed selected antibiotics for 3 calendar days. And this was actually more focused towards the provider driving some of the stewardship efforts. So the provider on days 3 through 5 were prompted by the clinical service during rounds to complete this stewardship tool. So they provided a list of the current antibiotics that are prescribed, the indication, their clinical assessment for it, and the plan for change. Their outcomes were to look at the hospital antibiotic days of therapy per the patient administration, also the total antibiotic days of therapy. So that included how their exposure to antibiotics while they're admitted, as well as their exposure upon discharge. They also looked at the portion of cases in which they modified or discontinued the therapy, as well as the appropriateness of regimen. So that's another factor that I'm always glad to see in a paper or any of our stewardship literature, is the appropriateness and that's being assessed. And for this particular study, appropriateness was defined as not being prescribed an antibiotic and there's no infection, or if it was too broad of an antibiotic that was being prescribed. And what they noted that there was no difference in regards to the days of therapy for hospital or the total. So that's hospital as well as outpatient. So there was no impact on that. They did note there was an increased number of antibiotics that were modified or discontinued. And so this increased by about 6% after the intervention. But upon subsequent analysis, there was no association that was found between antibiotic timeout and the modifications. What was encouraging, though, is that they did notice a decrease in the number of inappropriate antibiotic prescriptions. And so we can see the protective effect, perhaps, of having this antibiotic timeout and having a positive effect in regards to making sure that the appropriateness of the antimicrobials or antibiotics are maintaining, or at least having improving during your intervention. Next, I'm going to transition over to some stewardship interventions and initiatives that we have implemented recently at Lurie Children's, and so can speak to some of the incorporation of what's been recommended within the core elements of stewardship, as well as in the IDSA guidelines, and how that has been beneficial in regards to incorporating various departments in those initiatives. What is it in regards to our restriction policy? So we, prior to modifying our restriction policy at the time, we had multiple antimicrobials, and it was very specific to the particular indication if they needed approval at initiation of therapy or at 48 hours. And so we wanted to streamline this process and decrease the number of antimicrobials that required ID approval at those time periods. And this revision was based off of prescribing patterns at our institution, clinical practice, as well as appropriateness based off of the clinical scenario. The goals were to identify opportunities to avoid broad spectrum therapy, avoid adverse effects, as well as decrease costs. And we wanted to simplify the policy to focus on some of our higher yield antibiotics, as well as we did not want to negatively impact the workflow at our institution. So listed here is the restriction policy and the updates that we provided. So we did decrease the number of antimicrobials that required approval, and then looking specifically at the indication, determining if they needed approval at initiation of therapy or at 48 hours. So for example, the top half of the table includes antimicrobials that required approval at prescribing. And there were some exceptions, such as meropenem. If they were in the ICU, they were allowed to receive that for 48 hours, at which point they would require approval. We had a much more exceptions to requiring approval at the 48-hour mark based off of the indication. So for example, for Zosyn, hospital-wide, except in the ED, you require approval at 48 hours, except if it's for the indication of abdominal, pelvic, or for our cystic fibrosis patients. And as we go through for various other antimicrobials, it's very specific, the indication for that particular antibiotic, and that was based off of looking at our prescribing patterns. In regards to the process, the ordering prescriber, when they place an order, would be reminded in regards to if it required approval at the initiation of therapy or at 48 hours and for which specific indication. Listed at the bottom is an example of that. So We talked about meropenem in regards to the indication. It was pre-approved for 48 hours in our ICUs, and then anywhere else except in the ED within the hospital. And these are the specific indications that would be required to be selected during order entry. Then it would require ID approval. The ordering prescriber could page for ID approval, and this is throughout the entire week from 8 to 5. And then during off hours, they're prompted to also page for approval during the subsequent day at 8 o'clock in the morning. And then the stewardship personnel would document the ID approval via in-basket messaging so that the pharmacy was made aware in regards to the approval. And we have various methods to also monitor this, utilizing vigilance to get alerts when new orders are placed as well. So that's another backup method so that we can assist in monitoring. And after looking at our data, coming up with a plan, we wanted to make sure that we communicated with the various frontline providers so that they're aware of the change. And then also that was a way to generate feedback. If there's things that we weren't necessarily thinking of or we missed while we were brainstorming and trying to draft a revision, then this was the opportunity for us to receive that feedback and modify our process that we had planned to implement. So this was done via emails, messaging, as well as from lectures, so that it would assist in regards to disseminating that information. For our tracking, we continue to look at our days of therapy and baseline and then post-implementation. We also look in regards to the closure of those IVents. So the IVent, if it's open, then it helps us to identify that it's an active approval. If it is closed, then that's a notification that it's no longer active. So we wanted to make sure that we close that loop and that once that approval is no longer valid, that it's closed and hopefully prevent the inadvertent continuation of it or thinking someone looking at that open IVent and thinking that it is active. We also monitor the percentages of our verified restricted antimicrobials that did receive ID approval, and then we communicate that back to our leaders, division leaders within the various departments. Some of our other balancing measures include our time from entry of the order to administration. So we had our baseline data in regards to the turnaround time of that prior to our intervention, and we continue to monitor that to make sure that we do not negatively impact our workflow after implementing this revision in our policy. And then for the long term, we're also looking at our resistance patterns to make sure that while we're restricting antimicrobial utilization in certain areas for broad spectrum antimicrobials, that we are not having a negative impact in regards to our resistance patterns. So the second intervention that we recently implemented includes a modification to our antimicrobial ethanol lock algorithm. So as you may be aware, there was a significant increase in regards to the cost of ethanol that over the last spring. And so we were looking at our utilization of ethanol locks and brainstorming ways that we would be able to modify that utilization. And what we were considering and had implemented was providing guidance on when to utilize an antibiotic lock or ethanol lock for the treatment or prophylaxis against catheter line associated bloodstream infections. And we currently had in place a central venous catheter removal algorithm that provided guidance in regards to if a line should stay in place or when you should consider having ID's involvement with that or if it should be removed. And we wanted to incorporate our algorithm for the locks into a current and active and readily accessible algorithm. And so as part of that, we incorporated when patients should be considered for our antibiotic or ethanol locks. And these eligibility lists was drafted from a CLAPSI work group prior to us implementing this algorithm. And so to minimize confusion, then we looked at their high-risk patients for CLABSI, or patients that were at high risk for CLABSI, to help us determine if those patients would be eligible for antibiotic or ethanol lock. And their utilization or their eligibility was also based off of the risk for side effects, the type of line material. For example, if an ethanol lock is to be used, it cannot be utilized in a polyurethane line. It needs to be silicone. And so that's part of our eligibility criteria. And then also the feasibility of instilling the lock. So if that line is constantly being used and we really wouldn't be able to instill it, then that may be a patient that we may not be able to utilize the lock. So patients that had at risk for recurrent, had a documented incidence of recurrent bacteremia, could utilize an antibiotic lock in conjunction with IV antibiotics. And it can also be utilized for CLABSI prophylaxis. Ethanol locks could be used only for patients that were ineligible for antibiotic locks. So in addition to incorporating this into a currently standing algorithm, we also created an order set so that we could streamline the process, and that information was in one additional area during the order entry period that would help the provider. So this order set provides a list of criteria for antibiotic and ethanol locks. It also provides recommendations on the dwell time and the frequency of when you should instill the lock. And then it also incorporates a automatic ID consultation if ethanol locks are ordered. And this is done in an effort to help determine if this patient necessarily needs to have the ethanol lock or not, because it's something that would require there may be a little bit more complex case that would require additional input from the ID consult team. And along with the algorithm and the order set, we worked with our nursing colleagues in order to determine and modify a currently standing protocol. There was one already in place for ethanol locks, so we wanted to modify it to include antibiotic locks as well. And in this protocol, it references our other documents, the algorithm, as well as the order set. For monitoring, as the stewardship team, we're notified of new orders for antibiotic and ethanol locks, and then we also review the chart if there is an active order to determine if the patient is eligible and that it's safe to continue. And also if it's an ethanol lock that's ordered, that ID is consulted. And as we noticed with some of our other efforts, is very important in regards to education, and so that information was disseminated out. And what was very helpful was the Center for Quality and Safety, and working with them to be able to identify our key players and stakeholders. And those individuals were involved in this process, provided feedback so that we would be able to make this as user-friendly as possible. And then also at the implementation, helped us to disseminate information out to their respective units. And the final stewardship effort that I wanted to discuss is one specific to pediatrics in regards to single stage larotracheal reconstruction, or LTR. So this was something that we noticed as a stewardship team, that after status post this procedure, there were wide variation in regards to our use of antibiotics, as well as variations in the antibiotics that were selected. And so this was something that we were noticing while we were doing our daily stewardship activities. And the other consideration too is that there's not much literature in regards to this particular surgery and how long you're supposed to continue antibiotics. And we're aware of what's recommended within overall guidelines for surgical prophylaxis, but that may not be necessarily applicable to this particular procedure. And so this was actually a effort that was spearheaded by one of the surgeons, that they wanted to create a multidisciplinary work group to reduce clinical variation, as well as decrease the length of stay among patients that underwent this procedure. And they wanted to implement a post-operative clinical care guideline. And so from a stewardship perspective, we wanted to provide input in regards to the variation in antibiotics prescribed, as well as the duration. So some of the activities that we were involved in included looking at the guidelines, or surgical prophylaxis guidelines, looking at clinical literature, looking at guidelines from other pediatric hospitals. And at our own institution, we looked at our microbiology data among the patients that underwent this procedure in the previous 2 years, also looking at the variations of antibiotics and the duration. That included IV, oral, and topical, as well as the time to drain removal and extubation, because sometimes those parameters were utilized to determine the duration of antibiotics. So after looking at that, all of that information, the antibiotic stewardship team was able to provide recommendations on empiric antibiotics that could be utilized based off of the patient's microbiological data. So if they're able to get a trach or aspic culture and it grows Pseudomonas prior to the procedure, then we would recommend an anti-Pseudomonas agent for their surgical prophylaxis, and then provide recommendations during the entire procedure, so intra-op, post-op, peri-op, which agent should be utilized, the dosing, as well as the duration, and provided alternatives based off of the allergy history. And then after implementation of the algorithm, we met with a work group to determine compliance, and if there's anything that we can assist in from a ID or stewardship standpoint, and those meetings happen periodically after the implementation. So in conclusion, for stewardship initiatives, it's great to have a baseline assessment. So determining what's the best way for your stewardship team to communicate. And as we talked about the readiness board, that's a visualization that could be utilized and helpful for your institution. It went from one monthly meeting down to a weekly 15-minute touch base that helped to improve some of their stewardship outcomes. And this was a great way for them to incorporate the entire team. So that may be something to consider to implement at our institutions. And it also assisted in monitoring the status of the various projects to see if there's things that need to be addressed much more quickly, or if it's something that needs to be addressed with a more collaborative approach and reaching out to other departments. We also, prior to starting a stewardship initiative, can determine some potential stewardship initiatives as well as respective interventions. So one is in regards to an example of our LTR. So we noticed that there was a variation in our antibiotic use and variation in the duration. So we wanted to see if there's interventions that we could do, such as a clinical care guideline post-operatively, to assist in regards to that variation. And then determine if there's additional resources that are required. For example, you may need to reach out to see if you can get a data analysis. That person can help you to get a collection of all of your days of therapy, if there's micro reports that you need to be generated, or they can help in regards to submitting data such as to NHSN. Some examples in regards to initiatives are listed at that bottom table. So if an initiative is to decrease your days of therapy, we have various interventions such as prior authorization, prospective audit and feedback, handshake stewardship. We talked about some of those examples throughout the presentation, either that are published or things that we've implemented at Lurie Children's. And it's very beneficial to look at your resources and see if that's something, which one will work best for your stewardship team. Guidelines and algorithms are great, as we noted in the earlier study where we had that line of our days of therapy, that the clinical care guidelines can have an impact in regards to our days of therapy. And we can create these guidelines based off of common or targeted clinical scenarios, and we want to make sure that it's readily accessible to our end users. And education is very important. It's great to have that at the initiation of new interventions, that individuals are made aware of what interventions are coming out in our initiatives, and may have to re-educate throughout the time period as well. And this augments our stewardship initiatives, and in regards to making sure that everyone's aware of our common goal. So additional takeaway points, antimicrobial stewardship efforts within the pediatric population can impact our utilization. We can use target stewardship interventions based off of the needs of our institution, and that's just looking at, as you're going through your day-to-day and noticing perhaps there's something that needs to be targeted for your stewardship program to try to have improvements in regards to your outcomes. You also want to determine if there's resources that would assist in achieving these particular goals. If you need additional personnel, additional tools, or other resources to help with achieving those goals. Can identify and capture clinical outcome metrics. As we mentioned before, some of the traditional metrics may or may not be impacted by your stewardship efforts. And we definitely would want to make sure that we're not worsening those during the after the implementation of a stewardship initiative. Education is key, but only complements our stewardship efforts. We definitely will want to analyze the impact of our initiatives and be able to inform key stakeholders on those outcomes. And as we're all aware, stewardship is not done by one particular person. I would like to acknowledge our stewardship team at Lurie Children's, which is led by Dr. Samir Patel. And we also have a wonderful data analyst, Shen Sun. And then we have great pharmacy informatic coordinators, Dan and Mike. And then we work closely with various departments to help roll out and monitor our stewardship initiatives, such as data analytics and reporting, Center for Quality and Safety, as well as our wonderful Department of Pharmacy. And I would like to open it up for any questions.
And just so you guys know, you can use the chat feature to ask any questions.
Oh, one of the questions, thank you for that, is what were the criteria that you have in place for antibiotic locks? That's a great question. So it's based off of the patient's past medical history and physiological factors as well. It's quite extensive, to be honest with you, because we wanted to cast a wider net to prevent the risk for CLABSI, because when we're looking at our specific cost as well as outcomes secondary to CLABSI, that we wanted to prevent that as much as possible. And if we're able to utilize an antibiotic lock as opposed to the further development of a CLABSI, then we would prefer the antibiotic lock. So it's based off of physiological factors as well as the location of the device. If it's near an ostomy, then that's at higher risk. And so that was considered by the work group as one that we would consider for antibiotic lock, as well as if there were previous, if the device was replaced, then that may place them at higher risk, and so they would be considered a candidate for antibiotic lock. And it took a couple of reiterations and working with the hospitalists as well as with the pharmacy department and ID to be able to have an agreement upon those criteria. Oh, thank you. Oh, sorry, one more thing for the antibiotic block as well. We have started to utilize antibiotic impregnated lines. And because of the lack of experience and data in regards to if you instill an antibiotic into that line and what impact that has on the line and the antibiotics, then we have elected to not have that as an option if they do have an antibiotic impregnated line. So that places them as not being able to utilize that. And then depending on the line material itself, then that will determine if they're able and eligible for ethanol.
Dr. Scardina, thank you so much for such a great and informative presentation. You really did a well job. It was so clear and very interesting. And just wanted to remind you guys that there's just 3 minutes left. If you have any last minute questions, just stick around until our, we're just going to wrap up. We have one more session. So there's just 3 minutes left here. So if anyone has any more questions for Dr. Scardina, go ahead and put it in the chat. But if not, you can go ahead and take a quick break. But thank you again so much. It was a really great presentation.
Oh, thank you. Thank you for the invitation. And I would like to thank all the attendees for making it to the end of the day. So thank you.
Thank you. All right, I'm going to head on over to the last session here. So thank you again, everyone. And thank you again, Dr. Scardina. Thank you.
Thank you.
Bye.